Cognitive Behavioral Therapy. Boost your self-esteem and become free from anxiety, panic, and anger. Written by Zimbob Winston. Narrated by Rory Young. Chapter 1. Cognitive Behavior Therapy. What is cognitive behavioral therapy? Cognitive behavioral therapy, CBT, is a form of psychiatric therapy that focuses on customizing inefficient emotions, habits, and thoughts by interrogating and uprooting negative or illogical beliefs. Considered a solutions-oriented form of talk treatment, CBT rests on the idea that ideas and understandings impact conduct. Feeling distressed sometimes could misshape somebody's perception of reality. CBT aims to identify harmful ideas, assess whether they are a precise representation of real life, and, if they're not, utilize methods to challenge and overcome them. CBT was founded by psychiatrist Aaron Beck in the 1960s, following his disappointment with Freudian psychoanalysis and a wish to explore more empirical ways of therapy. CBT also has roots in rational emotive behavioral therapy, REBT, the brainchild of psychologist Albert Ellis. CBT is proper for people of all ages, including children, teenagers, and adults. Proof has installed that CBT can attend to numerous conditions, such as significant depressive disorder, anxiety conditions, trauma, eating disorders, obsessive-compulsive conditions, and many others. CBT is a preferred technique of treatment amongst professionals and insurance providers alike, as it can be effective in a brief time period, generally 5 to 20 sessions, though there's no set time frame. Research suggests that CBT can be provided efficiently online, in addition to face-to-face therapy sessions. How does CBT work? CBT focuses on present situation and feelings in real time, rather than youth events. A clinician who practices CBT will probably ask about family history to get a better sense of the entire individual, but won't spend inordinate time on past events. The focus is on what an individual is telling themselves that might lead to anxiety or disruption. An individual is then motivated to deal with reasonable concerns virtually and to challenge irrational beliefs, rumination, or catastrophizing. For instance, a person who is upset about being single would be encouraged to take real measures, but also question any unnecessary negativity or unwanted premise, "I will be alone forever and ever," that they attach to this contemporary fact. Chapter 2. Use cognitive behavior techniques to boost your beauty and self-esteem. I began using the term prettiness and self-confidence after a journalist asked me to specify the psychological difference between beauty and beauty. She asked, why do some people feel appealing even if they do not have model-like functions, although as others, like some sexy fashion models, on-screen actresses, and others who are well known for their prettiness, don't necessarily feel this way? I said to the journalist, physical functions are only a part of what makes an individual attractive, and her question was more about an individual's beauty self-confidence. You too may find this term useful in thinking of how you feel about your appearance. You see, attractiveness is more complex than meets the eye, a problem I have written about in former posts here. It is valuable to remember that beauty is both a physical and psychological experience. It's based upon 3 qualities: how we actually look, genetics; how we look after ourselves, health and grooming; how we feel about how we look, positive self-regard. The combination of these qualities is what I call prettiness self-confidence. Having one of them, good genes for instance, without the others, good grooming or positive self-regard, can cause a failure to feel appealing no matter how one appears to others. This part of the book is about ways to enhance beauty self-esteem using cognitive behavioral methods. Bear in mind that I'm not an appeal expert in the standard sense. That is, I am not a style or style authority, And these aren't attractiveness tricks that are sure to change your life. I, like lots of you, am sick of hearing those how-to ideas in commercials, publications, reality programs, books, and blog sites. Have you Googled beauty lately? We have become so accustomed to being told what we really need to fix that we forget that the entire concept of repairing actually detracts from feeling appealing. Instead, as a psychologist, I actually believe feeling better about ourselves requires internal work, and this applies to our appearance too. I help other people identify their thoughts and feelings about their self-image and find sensible ways to improve them. To achieve that goal, we need to understand the cognitive behavioral patterns we have about prettiness, learn how to modify them, and after that, use new ones to support our prettiness self-confidence. Below are 3 cognitive behavior therapy, CBT, techniques applied to the experience of attractiveness, starting with typical beliefs others have about prettiness, followed by a behavioral strategy that can be practiced to achieve change, and ending with a cognitive shift that enhances beauty self-esteem. Exercise 1. Cognitive belief. People tend to really believe that beauty is based upon a reality created by others. The truth is that you can learn how to define your self-image based upon your own requirements, rather than the reality created by your culture. Behavior pattern. Jot down 3 physical features and 3 aspects of your character that you like the most. If you have a difficult time thinking of any, try thinking of the features you are least critical of. For example, it could be, I work very hard, I like my eyes, I'm truthful, I'm a devoted good friend, I'm a really good athlete, and I have thick hair. Now put your list in order of importance and sophisticated by writing 1 sentence about each element on your list. Expected change. If you are like most men and women who have made this list, you will likely see the physical features you wrote were ranked lower than ones about your character. Though it might appear clear, this exercise puts physical attractiveness in perspective. It helps remind us that the core of our self-confidence is based upon personality qualities more frequently than our physical functions, even if our culture has us thinking otherwise. Physical attractiveness is just one element of our identity. Appearance is all about a lot more. Exercise 2. Cognitive belief. Looks matter to many people, but many puzzle beauty with perfection. Though no one truly looks flawless all of the time in each way, it is a belief supported by our media-driven culture. We all have had bad hair days, blemishes, bloating, and so forth, but airbrushing and Photoshop can really make them disappear. You can learn how to hang on to your imperfect core self-image, the sense of yourself that remains steady despite flaws, by acknowledging that variability is a fundamental element of true appearance. Behavior pattern. This exercise concentrates on your physical functions. Jot down 3 that you really believe are most attractive to you. Again, if you find this challenging, choose the 3 features you find least unappealing or ones that others tell you are appealing to them. For example, you may choose your curly hair, green eyes, and white teeth. Specify each feature in a sentence like, "My white teeth are attractive, especially when I smile." Use these to begin to identify the core of your prettiness self-confidence. Expected change. Remember, no one has perfect features, but everyone has at least a number of appealing ones. Those can add to the core of your self-image. You can learn how to use them for confidence and to improve your prettiness self-confidence. If you have curly hair, bring attention to it by wearing cool hats. If you have good eyes, wear clothes, makeup that highlight the color. Healthy teeth? Keep looking after them and use your smile to feel good about your looks. If you change the equation between excellence and beauty to a more reasonable definition, the chances are you are going to have the ability to improve your attractiveness, self-confidence. Workout 3. Cognitive belief. We are our own worst critics. Only few people find as many faults with their appearance as we do. We can change the way we speak with ourselves by changing negative thoughts and unreliable internal discussions with more positive, practical ones. Behavior pattern. Look at yourself in the mirror, and after that, listen to the very words that come into your head. Ask yourself, is the tone critical? Do the words remind you of anybody or sound comparable to those your mom once said? Your father? Siblings? Schoolmates? Then question the credibility of these words. Are they really precise? For example, do thick eyebrows truly make you look unattractive? Do the extra 5 pounds you carry mean you are fat? Now rewrite these discussions as though you were speaking to your good friend, sister, or daughter. If a good friend asked you how she looked, what tone would you use? Just look in the mirror and use that tone in an internal discussion you have with yourself. Expected change. We can move the way we see ourselves by practicing constant, encouraging internal dialogues. Instead of being critical and fixing ourselves, we can try to look the best we can and accept who we are. Use your own kinder internal mirror as a constant source of prettiness self-esteem, and you're going to feel and look more attractive. These are just some of the inaccurate ideas about attractiveness that have become hardwired into our thinking, but that can change by using the cognitive conduct strategies. The result is a shift in our internal lens that builds, rather than repairs, long-term self-confidence and beauty self-confidence. All of us should have to feel positive regard towards ourselves, and we clearly can't rely on our society to make that happen. CBT has been revealed to help people change attitudes, beliefs, and habits. Why not apply this method to change our method to prettiness? Chapter 3. How to Stop Believing the Negative Ideas of Depression. Countless women and men experience clinical depression each year. Being depressed is a miserable experience, as I know not just from my scientific work, but from personal experience. It's difficult to feel fully alive when you're down the whole time and having a hard time to find satisfaction in any activity. Poor sleep, low energy, mental fog, and other symptoms contribute to the pain. While there are very effective forms of treatment for depression, lots of people don't find them helpful or get only limited relief. An example would be the following. In the STAR-D trial, one of the largest depression treatment studies to date, only about 1/3 of depressed individuals were depression-free after 12 to 14 weeks of treatment with a selective serotonin reuptake inhibitor, SSRI. That was a better result than placebo, but it left 2 out of 3 individuals with significant signs of ongoing depression. Reliable forms of psychotherapy like cognitive behavior therapy, CBT, result in similar results, with many individuals improving but large numbers continuing to struggle with signs. Combining medication and psychotherapy, while partially better, is not the magic bullet of depression treatment. An example would be the following. In the STAR-D research study, about half of depressed individuals were still depressed, even after 12 weeks of medication plus 12 weeks of cognitive therapy. Mindfulness-based cognitive therapy. These constraints have caused the search for other possibly helpful treatments. I recently talked to psychiatrist Dr. Stuart Eisendrath about one such treatment called mindfulness-based cognitive therapy, MBCT. As the name indicates, it integrates the best-tested psychotherapy for depression with practices in conscious awareness, which involves focusing on the present and letting go of resistance to reality. Most kinds of psychological therapy concentrate on trying to get rid of signs. Traditional cognitive therapy, for instance, teaches an individual to recognize and challenge the negative automated thoughts that are very common in depression. So if your mind tells you, "You're such an idiot, you're always screwing things up," your therapist would work with you to identify those ideas and consider the evidence for and against them. Together, you would aim to develop more useful and fact-based perspectives. MBCT offers a very different approach in which you would work to change how you relate to depressive thoughts. Eisendrath used this handy metaphor to explain. If you are walking down the main street of a town, you may see some storefronts with various depressive thoughts on display, he said. Typically, in depression, you would get into the store and purchase those thoughts, and after that go back out and start walking down the street having those ideas with you. Cognitive treatment would also involve going into the store and straight engaging with the thoughts. You might explain to the shop owner that the thoughts on display are deceptive, implicate them in incorrect marketing, and need that they change the thoughts. Perhaps the shop owner would nod understandingly, agree with your points, and after that refuse to change the display. In contrast, a conscious response to the ideas includes seeing them through the window without entering into the store. You see the depressive thoughts in the store, said Eisendrath, and you do not get rid of observing those ideas. However, you don't enter and purchase them, and you don't have to carry them with you as you go down the street. This technique can be very handy for the ones that struggle to change their negative mindsets, which in my experience is a large percentage of individuals with depression. Even when they know logically that their thoughts are unrealistically negative and that they are being too hard on themselves, the ideas stubbornly continue. And paradoxically, discussing with your negative thoughts can make them appear more important, like an issue that has to be fixed before you can proceed and be in your life. A mindful response to depressive ideas allows you to let go of the struggle with them and to just exist side by side together with the ideas. You're able to continue walking down the street, said Eisendrath, and you can still go where you want in life, even with the negative automatic ideas. Mindful responses to depression signs. There are numerous strategies for responding mindfully to depressed mindsets. What all of them have in common is bringing our attention to what is happening now and adopting an attitude of approval. Just remaining in this moment helps reduce depression because you are not laying on that negative story about the future, said Eisendrath. You're just concentrating on the present. Here are some practices for changing your relationship with depressive thoughts. Be in the body. Getting in touch with the body is one of the most efficient ways of letting go of resistance and bringing your attention into the present. Eisendrath advised asking yourself questions like, what do I see as I am depressed right in this moment? A tension in the shoulders or chest? A headache? Rather than making these experiences a problem, be curious about your experience. What's going on in my body right now? Breathe. Like the body, the breath is always with you. Practice breathing with your ideas, feelings, and physical feelings. As the body opens to the breath, let your spirit open up to your experience just as it is. Focus on your senses. When you find yourself stuck in negative patterns of thought, come to your senses. Thoroughly note something you see, something you hear, and a touch experience you're aware of. The aim isn't to push the negative thinking to stop, but to change the channel, widening your attention past the narrow spotlight of upsetting thoughts. Do what's important. Depression typically fosters a focus on how we're feeling, why we feel that way, and how we can get rid of bad feelings. Doing something important to you can be a very mindful way to break depression's preoccupation with itself. Instead of concentrating on how you are feeling, ask yourself what needs to be done. Taking out the trash? Are you doing the dishes? Are you writing that email you have been putting off? Let the action be as huge or as little as you can manage. Perhaps for now it's just brushing your teeth. Seeing ourselves move through depression is one of the most efficient ways to change our relationship with hard thoughts and feelings. Chapter 4. Psychodynamic versus Cognitive Therapy. Many current schools of psychotherapy reject practically all of the ideas of the original one, psychoanalysis, PA, and its updated version, psychodynamic treatment. Part of this is the analysts' own fault. They usually openly assaulted critics of some of the principles, telling them they needed to enter psychoanalysis. to find out why they were resistant to the ideas themselves. Simply put, if you found some of the ideas bothersome, you had a mental issue. Added to this was experts' tendency to continuously support some of the more improbable, plainly wrong elements of their theory, such as penis envy in women and schizophrenic mothers. In point of fact, psychoanalysis is an entire collection of theories that interrelate, and so are all of the other schools of therapy. To think that if one of the sub-theories is wrong, then they all should be wrong, is black and white thinking, something cognitive behavioral (CBT) therapists themselves identify as illogical. And speaking of cognitive behavioral therapists, that is precisely what a lot of them did in C's to psychodynamic treatment, while doing so threw out the child with the bathwater. One of the more useful ideas from psychoanalysis, something that the majority of us acknowledge implicitly in our everyday lives, is that of defense mechanisms. As originally specified by Sigmund Freud, the creator of psychoanalytic treatment, a defense mechanism is a method developed by an individual, subconsciously, to safeguard against anxiety, specifically the anxiety created by disputes within the mind over somebody's biological impulses versus the values of the individual learned from his or her cultural milieu. For instance, when somebody's desire to have sexual relations with a complete stranger conflict with a belief in the social convention of not making love beyond marriage, unsatisfied emotions of anxiety come to the surface. To minimize these negative feelings, the ego might employ one of the defense mechanisms to either deny the existence of or undo the forbidden impulse. The most common defense mechanisms are called regression, repression, response formation, isolation of effect, undoing, forecast, introjection, turning against the self, and somatization. Interested readers that aren't familiar with the various PA defense reaction can find definitions of practically all of them here. Cognitive behavioral therapists, instead of analytically oriented therapists, turn down the entire idea of the unconscious and defense mechanisms, although they typically seem to recognize their behavior symptoms and just call them something else. They believe that apparently aberrant or conflicted conduct stems mainly from unreasonable beliefs. The first cognitive therapist was Albert Ellis, who came up with his theory at least a whole decade before his model was hijacked by another psychotherapy guru, Aaron Beck. Ellis listed some of these illogical beliefs. It is an alarming requirement for adult human beings to be loved or approved by essentially each loved one person in their community. Someone definitely must be proficient, appropriate, and attaining in all important respects, otherwise one is an insufficient, worthless individual. People definitely have to act considerately and fairly, and they're damnable bad guys if they do not. They are equivalent from their bad acts. It is terrible when things are not the way one would really like them to be. Emotional disturbances are mainly externally triggered, and people have little or no capability to increase or decrease their dysfunctional feelings and behaviors. If something is or may be dangerous or fearsome, then one should be constantly and exceedingly concerned about it, and needs to keep dwelling on the possibility of it taking place. A person can't and must not deal with life's duties and problems, and it is easier to avoid them. Someone should be quite based on others and really need them, and one can't mainly run one's own life. A person's past history is an all-important determiner of someone's present conduct, and because something once strongly affected one's life, it should indefinitely have a comparable effect. Other people's disturbances are horrible, and one must feel upset about them. There is invariably a right, precise, and perfect solution to human problems, and it is awful if this perfect solution isn't found. Cognitive behavioral therapists are beginning to reluctantly admit that unreasonable beliefs are typically connected to one's upbringing as a child. They originally really believed, and many still do, that they only occur just because people are basically and innately illogical. So who is right? The CBT folks or the PA folks? Well, naturally, both are right, and both are also wrong. Let me clarify. When I initially learned psychoanalytically oriented psychotherapy, I began to notice what somebody named the last psychiatrist discussed in the quote at the start this part of the book. Defense mechanisms were visualized by Freud as safeguarding the self against anxiety, but neurotic people were the most anxious people out there. Yes, indeed, defense reaction don't really stop anxiety at all. What defense mechanisms do, from my combined treatment perspective, is to block an individual's expression of inherent ideas and desires that run counter to the roles they feel they must play to maintain the consistent performance of their family of beginning, family homeostasis. If a belief or a desire disputes with that role, it needs to be blocked so that the individual does not change from their role behavior. This specifically is the change that's blocked. People actually try to exterminate parts of themselves that are incompatible with their social role, mortification. If this is indeed the case, it ends up being easy to see that the illogical beliefs noted by the CBTers also come in helpful. Many people use these beliefs to dissuade themselves from indulging in certain habits that they may otherwise want to do if they became self-actualized and stopped playing their role. Self-actualization is a term used by a third major overarching school of psychotherapy, emotion-focused treatment, which includes Gestalt treatment and client-centered therapy. It means the realization or satisfaction of a person's skills and potentialities. For example, a woman with a sex role dispute who secretly wants to be a vocalist rather than a homemaker as her sexist family needs will stop herself from being a successful vocalist if she thinks, overgeneralizing, that having actually failed one audition in variable means that she will never ever pass one in the future. That holding true, why bother trying it in the first place? Simply put, the illogical beliefs noted by Beck and Ellis serve the exact same function as defense mechanisms. One could say, in fact, that they're defense reaction. I once suggested to Albert Ellis during a Q&A at a therapy conference that maybe unreasonable beliefs and defense mechanisms serve the same purpose. He naturally launched into an ironical tirade at me for bold to even think something like that. Chapter 5. Is cognitive therapy a treatment for misophonia? Last year I had the pleasure of speaking with Arjan Schrader and Nienke Sivulink in regard to their 2017 short article, Cognitive Behavior Therapy is Effective in Misophonia, an Open Trial. Please note that Dr. Schroeder at the time was a doctoral student under the guidance of Dr. Damien Dennis. Writing this book was rather delayed, yet I think the timing is appropriate. At least 3 to 4 times a week, somebody with misophonia asks me if CBT works. Apart from this, there are many medical professionals and researchers suggesting CBT as a standalone treatment for misophonia, instead of as a part of a larger survival skills management plan. In their paper, the authors report that CBT is effective in 48% of their clients. Especially, the criterion for effective was showing a 30% or greater reduction in their symptoms, as gauged by the really same scale that this research team created, the A-MISO-S. The authors beware to point out that this is not a claim that CBT is effective. Rather, it is a candid reporting of the results of their own open trial, i.e., their interference was helpful to almost half the individuals, but only with a 30% reduction of signs. It is essential that we both view and use this information to notify further treatment research. It is even interesting that even though the title of the chapter suggests that the researchers used CBT, their interference actually included a lot more multifaceted approach. Notably, what these and many other medical professionals call treatment, I would define as coping skills development. Yet, for the moment, let's put this distinction aside and call it rhetorical, although ultimately I do believe it is important. First, it is very important to discuss that Arjan Schrader and the AMC group suggested that misophonia ought to be classified as an OC and related disorder in the DSM-5 in their 2013 paper. At the time, Schrader was just starting to look at misophonia, as were others in the field. Aside from that, the classification of OCD changed to OC and associated conditions from the DSM-4 TR to DSM-5. This is also part of the confusion that continues to negatively impact analysis. That is, the DSM is far from a best diagnostic instrument, to say the least. For the record, Dr. Dennis's and Schrader have both told me that they no longer totally agree with this original notion. That is a really crucial step for those that experience misophonia, and for those who are at the leading edge of misophonia research. Significantly, other scientists still suggest that misophonia is an OC and associated disorder. As a result, these scientists continue to suggest interventions, such as graded direct exposure treatment, which I will discuss later in the post. This still leaves us in a great deal of confusion. It's interesting to look a bit farther into this. One of the reasons misophonia is continuously compared to other psychiatric disorders could have to do with the higher prevalence of adult researchers intrigued by the disorder, as contrasted with early youth researchers. There is a misconception that kids don't have misophonia. That just isn't true. Many young children have misophonia, meaning the exact same trigger sounds followed by an immediate fight-flight response. In a kid, one can see this reactivity in its more organic form. Children react with a variety of discernible habits when exposed to set-off noises. These habits include crying, positioning their turn over their ears, running away, and yes, sometimes aggressive words or gestures toward another, if the sound is originating from an individual. Nevertheless, most of the time, and I'm not saying all of the time, when the trigger sound is eliminated, the kid instantly appears to go back to homeostasis, or a calm state. When you see this, the idea that a child is obsessing over the sound fails. Again, research tells us that misophonia co-occurs with various psychiatric, developmental, and health conditions. Because of that, it is possible that these disorders may overlap. Having said that, it is definitely not definitive. Seeing misophonia in a really young child also unmasks the idea that anger is the only feeling involved. I have seen children crawl under sofas rather than be aggressive. Back to the interview. Why was I surprised by what I heard about the treatment at AMC? Well, as the Scholastic paper suggests, I assumed I was going to hear about CBT. Yet, the AMC misophonia treatment plan includes much more than CBT. The treatment paradigm includes group treatment that helps victims disconnect negative emotions from noises, in addition to attention training and some desensitizing to the sounds. Still, concerning desensitization, the person was in control of the sound exposure in the treatment trial. So, do not confuse this with systematic desensitization, graded exposure therapy, which I'm going to address later. As a matter of fact, Dr. Dennis's is adamant that he doesn't have faith in this kind of exposure treatment for misophonia. Although, the short article defines these 4 aspects of treatment as different kinds of CBT. I think it is worth exploring each facet on its own. Let's start with group therapy. As Dr. Schrader mentioned, it is valuable for people with misophonia to meet others with misophonia. This is exactly why the group chose group therapy. As Dr. Schrader said, and I am paraphrasing, meeting others with the same disorder helped people to feel less alienated. Definitely, group treatment can be tough for the ones with misophonia. Yet, if the AMC team had the ability to supply an environment where group support was handy, then this is important information to consider. We all know that people with misophonia often utilize support groups. I want to know more about how the AMC group avoided the apparent challenges to misophonia group therapy. Next, let's look at the idea of attention training. Part of the treatment involved participants playing physically oriented games, meaning bouncing a ball attached to a paddle, in order to distract them while dealing with activating circumstances, Example, while people are eating. Learning how to refocus attention from upsetting sounds can be useful. According to the researchers, once an individual knows they can refocus attention, it has a general calming influence. Because those with misophonia feel attacked by the environment on a continual basis, any control that one can implement is easing. Learning how to refocus can be empowering and may help one to feel a bit less overwhelmed by the disorder. However, there's a difference between some alleviation in terms of the tension that originates from living somebody's life with misophonia, as opposed to the neurophysiological reactivity the individual experiences in the moment. To put it simply, it is challenging to refocus one's attention in the face of trigger sounds or visual stimuli. Lots of people ask me why individuals with misophonia focus more on trigger sounds than other stimuli in the environment. I am usually asked by parents or caretakers, instructors, and others, why does a person look right at the individual who is making the sound instead of turning away? This is a question that is certainly worth some paragraphs. I have typically said that a simple clarification of misophonia is the brain is misinterpreting sounds as though they are pretty dangerous or harmful, and subsequently the fight-flight system is activated within milliseconds. Nevertheless, before we can translate or misinterpret acoustic stimuli, we must signal to it. Informing to sounds prior to realizing that we're doing so involves pre-attention. Science hasn't exposed precisely when attention moves from pre-consciousness to conscious. Nevertheless, our brains focus our attention based on a hierarchy of survival benefit without our knowing it, or choosing where or what to address. Eventually, the conscious mind permits us to think about what we are attending to and can make modifications. Remarkably, this is a procedure the AMC group has taken a look at in misophonia. I know I always use the example of a pet dog. Nonetheless, it's a great one because most of us have seen how our canine good friends react to sounds in their environment. Think of how a pet dog punctures up its ears when it hears a sound that could indicate a prospective danger. This could be a loud sound or a quiet sound. Without thinking or conscious awareness, the pet dog's brain will inform to these sounds as potential risk cues. We have all seen a dog go on high alert in response to a sound or perhaps a smell. The pet dog becomes watchful and stays that way till he knows he's safe. We see the pet dog's pre-attentive state, pricks up the ears even if sleeping, and we see the dog either returning to sleep, approaching the sound and possibly growling to safeguard territory or the pack, or running under the closest space to hide. Retraining attention is definitely a reasonable idea on its face. Nonetheless, given the power of pre-attention, especially involving potential hazard, we should comprehend that this is an extraordinarily uphill struggle and exceptionally tough to learn. We are battling against part of our survival system which has been perpetuated throughout advancement. I'm not saying we should not try to develop this skill, but do not expect it to be a trusted remedy. I do really believe that engaging in exercise that requires attention can help the brain override pre-attentive and even conscious attention to triggers. Trigger noises might be less obvious to a person in motion. Having said that, it is also true that we process sound and all of our senses in a different way when we are moving. Therefore, we may extrapolate that movement itself contributed to some of the trial's efficacy. Regardless, practicing this in a synthetic setup versus doing this in real life are really different. This is usually a pitfall with treatment studies. Lastly, separating trigger sounds from the feelings that accompany them within the group treatment process. Of course, this is practical, extremely useful. Yet, this is not a procedure as simple as separating an egg white from its yolk. Actually, it is a very complex process moderated, again, by autonomic nerve system stimulation happening before cognition can be employed. The ability to use cognition to separate trigger sounds from emotions is also affected by age, development, and variations in character, memory, and far more. It is a really crucial objective for individuals with misophonia. Yet to understand the complexity of the connecting forces of automatic unconscious reactivity and the mindful statement of an emotion is far from easy. In conclusion, we can't hold up the CBT flag for misophonia treatment just yet, and it appears evident that more scientists concur about this, while also coming around to what misophonia patients have known the whole time. Graded direct exposure therapy for the purpose of habituating to sounds doesn't work. It is great to see psychologists and psychiatrists trying to find misophonia treatment. Having said that, I hope as the research progresses, with more unity and knowledge, we will also move toward more multidisciplinary research and treatment trials. Chapter 6. Social Healing Treatment. Social healing treatment is a cognitive behavioral intervention created to help bring back a more capable mindset to youths with schizophrenia by enhancing social skills and encouraging more participation in social activities. The goal is to help people during first episode psychosis increase the amount of time they spend actively involved in social settings to prosper in their community, rather than simply survive as outsiders and consequently preventing long-term social disability. When it's used. Social healing-oriented cognitive behavior therapy is used to identify and deal with the needs of teenagers and young people with early psychosis, multifaceted comorbidities, and severe social specials needs who aren't motivated to engage in organized activities. Supporters suggest that social recovery treatment plus early interference at the time of the first episode of psychosis is critical for preventing the early social decrease associated with a bad, long-lasting diagnosis for schizophrenia, because inspiration to change is greatest in the early phases of diagnosis. What to expect. In addition to helping people adapt to work, education, and leisure activities by learning and practicing necessary skills in a safe environment, social healing interventions intend to reduce any feelings of anxiety or despondence that may disrupt social success. Patient and therapist work closely together to establish social objectives and expectations, then match those objectives to appropriate firms and activities, like professional counselors, academic groups, and recreation center that host sports and other social activities. Meanwhile, treatment concentrates on reducing any negative emotions that are interfering with the capability to participate in new activities. How it works. Historically, there has been some dispute among psychotherapeutic specialists as to the true value of social healing therapy as an early interference treatment for those with psychosis. While lots of these clients already get early interference services that can result in partial or even full healing, some lack the motivation to participate in conventional interventions and continue to have trouble with social functioning. These early social difficulties invariably become long-lasting problems of seclusion, alienation, and complete lack of incorporation into the community. Other than the personal effects of functioning impairment, proponents of social recovery therapy mention the financial stress on the community as a consequence of lost efficiency. Early research studies suggest that social recovery-oriented cognitive behavioral therapy with early interference is well received and helps increase the amount of time clients invest in systemized activities by as much as 8 hours a week. Ongoing research is helping to figure out the long-lasting benefits and effects of social recovery therapy for people with schizophrenia and for civilization at big. What to try to find in a social healing therapist. Look for a certified mental health professional with specialized training in cognitive behavioral therapy, knowledge of social recovery interventions, and experience working with more youthful people in early phases of schizophrenia. In addition to these qualifications, it is necessary to find a therapist with whom you and your family feel comfortable working. Chapter 7. The 4 Downsides of Cognitive Therapy. For all its effectiveness, cognitive therapy also has its weaknesses. Cognitive treatment is a generic term that describes diverse cognitive approaches to modifying human experiences and activities. This review concentrates on cognitive therapy that concentrates on altering negative self-concepts. This approach is based upon the theories developed by A. Beck and A. Ellis. The self-focused cognitive approach presumes that it is illogical or negative cognitive beliefs about the self, rather than negative activating experiences that cause negative emotional states, or depression or anxiety, and dysfunctional conduct. The behavior includes a sense of defeat and the withdrawal of financial investment in people and in standard goals, and also an intensified sense of vulnerability. The purpose of cognitive therapy is to reorganize the client's unreasonable, negative, and/or distorted beliefs into reasonable, accurate, or positive ones. Although self-focused cognitive treatment has been shown to be remarkable to medication treatment for symptoms of depression and anxiety, it also suffers at the very least the following weak points. First, this model appears to confuse the signs, i.e. negative self-concepts, of depression with its cognitive causes. Examples of the negative cognition include low self-esteem, self-blame, self-criticism, negative predictions, unpleasant memories, erroneous analyses of experiences, all-or-nothing thinking, dichotomous thinking, leaping to conclusions, selective abstraction, overgeneralization, or exaggeration of negative experiences, the presence of a negative cognitive shift. Example, positive info pertinent to the person is filtered or blocked out, while negative self-relevant info is readily confessed. Simply put, for those people, negative cognitions penetrate internal conversations about self-evaluation, attributions, expectancies, reasonings, and recall. Are they the cognitive causes, or are the symptoms? I think that the former instances all represent the signs. In other words, they are not the cognitive reasons that people engage in self-blame, exaggeration of negative experiences, or other types of distorted thinking. Second, this cognitive therapy uses such terms as negative self-concepts, irrational beliefs about the self, dysfunctional self-concept, and biased cognitions about the self, as though they are associated and interchangeable. In fact, they have varied meanings. Research has revealed that the valence of evaluations, that is, being positive or negative, is independent and separate from the accuracy of evaluations. In a lot of cases, clients' appraisals and reports of their negative or distressful experiences are quite logical, sensible, and accurate. For instance, their experiences of sexual or physical abuse at the hands of another or the catastrophes of their loved ones have left huge scars in their life. In such scenarios, cognitive restructuring exercises, with their focus on reframing reality and not on changing it, don't handle the true issue. Third, research has shown that positive self-evaluations could be inefficient and maladaptive. It is often the positive instead of the negative self-assessment that is characterized by inaccuracy and predisposition in the fields of health, education, and the workplace. Fourth, the self-focused cognitive model puts a strong focus on taking a look at the association between negative thoughts and psychological dysfunction, but it has not replied the question of why individuals choose to focus on their negative characteristics when the positive examination of the self is more accurate. Neither cognitive model sufficiently reconciles the two types of finding: 1. Self-blame bias, and 2. Self-serving predisposition. Research has revealed that people have the inspiration to see the self favorably and stay away from an unfavorable self-concept, displaying a self-serving bias consisting of blaming failures on the situation while taking credit for success. Chapter 8. Acceptance and Commitment Therapy. Acceptance and Dedication Therapy, ACT, is an action-oriented approach to psychotherapy that comes from standard behavioral therapy and cognitive behavioral therapy. Clients learn how to stop avoiding, rejecting, and struggling with their inner feelings, and instead accept that these deeper emotions are proper responses to certain situations that should not stop them from progressing in their lives. With this understanding, clients begin to accept their problems and hardships and commit to making necessary changes in their behavior, despite what's going on in their lives and how they feel about it. When it's used. ACT has been used efficiently to help treat workplace stress, test anxiety, social anxiety disorder, depression, obsessive-compulsive disorder, and psychosis. It has also been used to help deal with medical conditions like chronic pain, substance abuse, and diabetes. What to expect. Working with a therapist, you're going to learn how to listen to your own self-talk, or the way you speak with yourself specifically about traumatic events, troublesome relationships, physical limitations, or other issues. You can then decide if a problem needs immediate action and change, or if it can, or must, be accepted for what it is, while you learn how to make behavioral changes that can impact the circumstance. You might look at what hasn't worked for you in the past, so that the I therapist can help you stop repeating thought patterns and habits that are causing you more problems in the long run. And when you have faced and accepted your present problems, you make a dedication to stop fighting your past and your feelings, and instead begin practicing more positive and positive conduct based upon your personal values and goals. How it works. The concept behind ACT is that it is not only inefficient, but also disadvantageous to try to control uncomfortable feelings or mental experiences, because suppression of these feelings eventually causes more distress. ACT adopts the view that there are actually valid options to trying to change the way you think, and these include mindful conduct, attention to personal values, and dedication to action. By taking steps to change their conduct while, at the same time, learning to accept their psychological experiences, clients can eventually change their mindset and emotion. 1. The ability to endure uncertainty. Studies have revealed that intolerance of uncertainty is a key part of anxiety, stress, and depressions. People who can't tolerate unpredictability typically keep away from circumstances, postpone, seek reassurance continuously, hold up acting, do extreme monitoring, and refuse to entrust. 2. The ability to recognize rumination. Rumination is when you are consistently bothered by a worry idea. When people ponder, their issue-solving capacity is decreased. If you are ruminating, it is typically best to wait to attempt to issue resolve until you can think of the issue without jumping straight into rumination mode. If you can learn how to recognize when you're pondering, you can use cognitive behavior therapy techniques, diffusion methods, or mindfulness methods to help you stop pondering. The best thing you can do when you're ruminating is accept that you are having whatever thoughts you are having, recognize that the ideas may not be accurate, and enable the thoughts to pass in their own time instead of trying to block them out. Trying to block out traumatic thoughts will just cause increased strength and intrusions of the ideas you're attempting not to have. 3. The ability to recognize idea distortions. Types of thought distortions include making excessively negative forecasts, underestimating your ability to cope, personalizing, mind reading, catastrophizing, shoulds and musts, making judgments of yourself or others that are black and white instead of gray, privilege ideas, meaning thinking that the regular rules shouldn't actually apply to you, and more. The key to recognizing thought distortions is to ask yourself what ideas you're having when you feel distressed. Some of these ideas are likely to be thought distortions. 4. The ability and determination to use mindfulness strategies. Mindfulness strategies can help reduce anxiety and increase willpower. Practicing mindfulness will help you stop avoidance coping, make better choices even when you're feeling anxious, and help you ruminate less. Try this 10-minute conscious walking exercise to get going. 5. The capability to talk to yourself kindly about your imperfections and mistakes. Criticizing yourself harshly when you make a mistake or when one of your personal flaws appears is very likely to cause rumination and avoidance coping. Research has shown that speaking with yourself kindly not only helps you feel better, it also increases your inspiration for self-improvement. Chapter 9. Does the 12-step program work because it's a type of cognitive behavior therapy? Most people think of AA as a spiritual process with its primary focus on giving everything up to God or a higher power. Implicit in this idea is a forfeiture of personal responsibility, free choice, and self-determination. The truth is, though, that AA most likely works because it shares many things with CBT, like thinking differently, acting in a different way, and actually taking personal responsibility for one's decisions. Undoubtedly, if we look carefully at AA, we see that in spite of its spiritual underpinnings and focus on working the 12 steps, it is a really behaviorally oriented process. An example would be the following. One of the core suggestions that AA makes is to change people, spots, and things. Simply put, to change one's regimens, repertoires, and actions. Surprisingly, this echoes the advice of Dr. Arnold Lazarus, who in 1958 was the first individual to introduce the terms behavioral therapy and conduct therapist into the expert literature, who often tells his clients to do things differently and do different things. Since it is a central tenet of CBT that thought and action can and do influence emotions and even brain chemistry, it is not a surprise that changing what we think and how we act can have an effective effect on how we feel, even to the degree of loosening the grip of powerful dependencies. Even the giving up to a higher power aspect of AA is firmly rooted in a behavioral dirt, in that AA members frequently say, "Pray like everything depends on God, but act a lot like everything depends upon you," and "fake it till you make it." Both of these little bits of guidance carefully mirror the cornerstone of CBT, particularly that how you act, so will you think and feel. Here is an example. People who conquer fears, phobias, and even obsessive-compulsive anxiety do so by refusing to act afraid, regardless of their fearful feelings and restless ideas. With time, this leads to genuine shifts in thinking and feeling, so that they enter into alignment with the non-fearful behavior. For that reason, people fake it, not being anxious or phobic, till they make it, overcoming their fears. What's more, working the steps farther enhances the restorative thinking and corrective action, meaning CBT, elements of AA, simply because it motivates people to develop more self-awareness, a browsing and brave ethical stock of ourselves, face fears, make amends, engage in self-monitoring, continue to take a courageous inventory, take some responsibility, when we are wrong, immediately confess, and change one's consciousness through prayer or meditation. In addition, the AA group process, consisting of self-disclosure, mutual support, and observational learning, parallels tons of the features found in cognitive behavior therapy groups. Now, this isn't to say that AA and CBT are associated or interchangeable, but that AA might owe its success to the parts of the program that are a lot like CBT, one of the most empirically supported and evidence-based therapies in the psychological arsenal. This has been Cognitive Behavioral Therapy. Boost your self-esteem and become free from anxiety, panic, and anger. Written by Zimbab Winston. Narrated by Rory Young.